Okay, I have shared the presentation file with all of you people. So, okay, today's class is basically continuation of the series of classes, which is basically chronic disease prevention. So there are many chronic diseases such as diabetes, heart failure, hypertension, etc., which can be prevented and which are preventable diseases, which are non-communicable diseases. And these diseases, if we have a very good and healthy lifestyle, we can prevent these diseases from occurring, or at least we can delay their onset, even if we are genetically susceptible to contract these diseases. For example, if there is a history of diabetes mellitus in a family tree, then there are chances that many of the people in that family will contract diabetes mellitus at some stage in their life. But it depends upon us whether we become diabetic at the age of 40, or whether we become diabetic at the age of 65 or 75. So it all depends upon our eating habits, our lifestyle, and our healthy habits. So basically, today's topic of our class is chronic disease prevention. It's part two of our lecture series, and today's topic is about hypertension. So prevention and management of hypertension is our today's topic of the class. As you all people already know who I am, I'm Dr. Omer Farooq Khan. I'm a resident surgeon doing my further specialization in orthopedic surgery in Rawalpindi Medical University here in Pakistan. So, basically, the things we are going to talk about today, that is my teaching style. First of all, we will go into the introduction, then basic definitions, then brief summary of the previous class, then epidemiology of hypertension, then types of hypertension, then pathophysiology and clinical signs and symptoms of hypertension will be discussed. Then we'll discuss how to approach a patient with the hypertension, then diagnosing a patient with hypertension, and then management strategies for hypertension. So, introduction. Hypertension, as we already know, ranks among the most common chronic medical conditions characterized by a persistent elevation in arterial pressure. Hypertension has been among the most studied topics of the previous century and has been one of the most significant comorbidities contributing to the development of stroke, myocardial infarction, heart failure, renal failure, etc. More than 1 billion adults worldwide have hypertension, with up to 45% of the adult population being affected by the disease. More than with up to 45% of the adults in some countries, yes. In some countries, up to 45% of the adult population has been affected by this disease. The high prevalence of hypertension is consistent across all socioeconomic and income strata, and the prevalence rises with age, accounting up to 60% of the population above 60 years of age. So if a person is above 60 years of age, there are 60% chances that he or she will have hypertension. Or if we take a number of people who are above 60 years of age, for example, if we take 100 people who are above 60 years of age, more than 60 people would have hypertension by default. In the year 2010, the Global Health Survey report published in Lancet Studies, which was comprised of patient data from 67 countries, reported hypertension as the leading cause of death and disability adjusted life years worldwide since the year 1990. In the United States, hypertension alone accounts for more cardiovascular disease related deaths than any other modifiable risk factor, and is second only to cigarette smoking as a preventable cause of death for any reason. Recent estimates have suggested the number of patients with hypertension could increase as much as 15 to 20%, which could reach close to 1.5 billion by end 2025. Yeah, and this figure is about to get reached because by this year there are almost 1.3 to 1.4 billion patients suffering from hypertension worldwide. So we are about to touch this milestone, this drastic milestone of 1.5 billion by end 2025 um, of patients suffering from hypertension. Most cases of hypertension are idiopathic, which are also known as which is also known as essential hypertension. It has long been suggested that an increase in salt intake increases the risk of developing hypertension. So we have covered some basics of the hypertension. Now I will deep dive into the basic definitions so that we know what we are talking about before going into the depth of the topic. Hypertension. What is hypertension? Hypertension is defined as chronic elevation in blood pressure, systolic blood pressure of more than 40 millimeter of mercury, or diastolic blood pressure of more than 90 millimeter of mercury in subjects aged 18 years and above. The above applies to individuals on antihypertensive medications even if current blood pressure is less than 140 or 90 millimeter of mercury. So if a person is having a blood pressure of more than 40 millimeter of mercury, he's or she is straight away suffering from hypertension. But even if a person who is currently on antihypertensive medications and after taking antihypertensive medication, their blood pressure reading comes around 130 or 125 millimeters of mercury, then they will be labeled as hypertensive because they are taking antihypertensive medication. And again, even after taking antihypertensive medication, their blood pressure range is going around 115 or 120 millimeter of mercury or 125 millimeter of mercury. So basically, if a patient is taking medications, then for hypertension, then it will not rule out that the patient is not suffering from hypertension, even if the patient's blood pressure remains below the mark of 140 or 90 millimeter of mercury for longer periods of time. Hypertensive urgency, severe elevation in blood pressure, in which systolic blood pressure of more than 180 millimeter of mercury and diastolic pressure of more than 120 millimeter of mercury without progressive and organ damage is called hypertensive urgency. So basically, there are two terms: hypertensive urgency and hypertensive emergency. These both terms come under the umbrella of hypertensive crisis. So in hypertensive crisis, then we define the terms as hypertensive urgency and hypertensive emergency. So there is a difference between hypertensive urgency and hypertensive emergency, and the difference is one basic difference, that is presence or absence of an organ damage. So if there is an organ damage due to severe hypertension and it is documented clinically, then the hypertensive urgency converts into hypertensive emergency, because now that hypertension is damaging one of our organs. For example, hypertension damages our eyes, hypertension damages our kidneys, hypertension damages our brain, hypertension damages our heart. So if hypertension is occurring but it has not started damaging our organs, then it is hypertensive urgency. But if we are seeing any kind of end organ damage such as brain, heart, kidney, eye damage, etc., then it is hypertensive emergency. Malignant hypertension. Abrupt elevations in BP in patients with chronic hypertension or sudden onset of severe hypertension with diastolic BP, often more than 130 millimeter of mercury, that is called malignant hypertension. What is resistant hypertension? Persistent BP recordings of more than 140 or 90 millimeter of mercury despite treatment with three antihypertensive agents of different classes, one of which should be a diuretic in adequate doses, and after exclusion of false hypertension, then that hypertension is called labeled as a resistant hypertension. For example, if we give a patient with calcium channel blockers, if we give a patient with angiotensin receptor blockers, and along with the angiotensin receptor blocker, we also give the patient with a diuretic. A diuretic is a medication which loses salt and water from the kidneys in the form of urine, which lowers the blood pressure of a person. So if a person is taking triple kind of medications, but still their BP remains more than 140 over 90 millimeter of mercury persistently, then that is called resistant hypertension. Then white coat hypertension or isolated office hypertension refers to a condition where a person's blood pressure is significantly higher when measured in a clinical setting, like in a doctor's office, but is normal when measured at home or during regular daily activities. So, white coat hypertension is basically a clinical hypertension as well because if a patient comes to you in a clinic and in a hospital environment, and you check the patient's blood pressure, and the patient's blood pressure comes out to be elevated, but when the same patient gets his bp checked at home or at some stress-free environment, their blood pressure comes normal, then that is called white coat hypertension. So, brief summary of previous class. In previous class, as we already know, we discussed the chronic disease of diabetes mellitus. So, understanding of diabetes mellitus in previous class was established. Type 1 and type 2 diabetes mellitus differences and definitions were discussed. Pathophysiology and clinical signs and symptoms of diabetes mellitus were discussed in detail. We discussed the healthy habits to keep our insulin resistance in check, and then basic management of diabetes mellitus was discussed in detail in our previous class. So, as we already know, today's class is about hypertension, and previous class was about diabetes mellitus. Both are chronic diseases and both are preventable diseases. That's why we are studying these diseases. So, understanding hypertension. In this section, we will discuss all the brief details regarding the basic understanding of hypertension. So, epidemiology of hypertension is we will discuss it in detail. According to the World Health Organization, the most recent global prevalence of hypertension is estimated to be around 26% of the adult population aged between 30 to 79 years, which translates to approximately 1.28 billion people with hypertension worldwide. So it's the average of the whole world. So 26% is the average of the whole world basically. And there are some countries where hypertension is even greater than that. For example, in my country, more than 40% of the adult population is suffering from hypertension, and there are some countries where nearly 45 or even more than 45% of the adult population is also suffering from hypertension. But across the globe, there is an average of 26% of the adult population which is suffering from hypertension worldwide. Key points about global hypertension prevalence: high burden in low and middle income countries. So even those countries where the incomes are low, where the poor population is greater in number, the hypertension is greater in number due to stressful conditions of the poverty and financial crunches and the financial problems the people suffer from. Lower and middle income countries, that is why there is high burden in low and middle income countries there are many people who are suffering from hypertension in such countries. Then unawareness and poor control is the second most common reason. A significant proportion of people with hypertension are unaware of their condition, and only a small percentage have their blood pressure adequately controlled. Then major health concern, hypertension is considered a major risk factor for cardiovascular diseases like heart attacks, strokes, contributing to a significant number of deaths globally as well. Hypertension contributes to more than 7 million deaths annually. Increased prevalence may be as high as 50% in patients more than 65 years of age. So basically, in more than 65 years of age, there are some countries in which almost half of the population who is above 65 years of age is suffering from hypertension. And hypertension directly or indirectly contributes to more than 7 million deaths annually. In Africa, prevalence is about 25 to 35% in patients of 25 to 65 years, and in USA, prevalence is as high as 48% in patients aged 25 to 75 years. In Kenya, according to STEP survey 2015, 24% either had hypertension or were on treatment for hypertension, and more than 56% of Kenyans have never been screened for hypertension at all. And only 15% of those with hypertension are aware of their hypertension status. Only 8% are on treatment, and only 4.6% of those on treatment are well controlled. According to most recent guidelines by American Heart Association, there are some gradings of hypertension. So these grading of hypertension are as follows. So it used to be a school of thought that normal blood pressure is between 120 to 130, and if blood pressure is below 120, then it is considered hypotension. But it's not like that. Optimal blood pressure should never touch the bar of 120. So optimally, a patient should have a blood pressure ranging between 110 systolic to 119 systolic. if a person if a person's blood pressure starts touching 120 systolic and more than 80 diastolic, then that can be considered normal up to 129 millimeters of mercury, but that is not optimal. That is a normal upper limit. So basically, even if the patient's bp is 125, 126 systolic and 83, 82 diastolic, we still call it normal blood pressure, but it is not optimal. So optimal blood pressure is less than 120 and less than 80 diastolic, less than 120 systolic. But normal limits, for the sake of theoretical knowledge and for the sake of for the sake of creating some guidelines, we still label a patient as having a patient as being normotensive, even if the patient's blood pressure is around 125, 126 systolic in routine. But as long as the patient's BP remains below 130 mark, the patient's BP is considered normal. Then there is a term called high normal, in which patient's blood pressure is 130 to 139 and diastolic blood pressure is 85 to 89, and it is not considered optimal or normal these days, and patient is considered a risk factor for hypertension, and they are encouraged to start making life choices such as avoid sedentary lifestyle, avoid salty food, start having good exercise, start eating less sugars and less salty foods. So that is why a high normal limit is created, in which a patient is deemed as a risk factor for developing full-blown hypertension. And when 140 marks cross, then that is called grade 1 hypertension, and then when 160 mark crosses, then that is called grade 2 hypertension, and then when 180 mark crosses, and then that is called grade 3 hypertension. And there are some instances when the diastolic pressure remains below 90 degree of Celsius, but there are uh, high systolic blood pressure readings repeatedly, such as upper blood pressure or systolic blood pressure is around 160 millimeter of mercury, but diastolic pressure is persistently coming below 90 millimeters of mercury, then that is called isolated systolic hypertension. But most of the patients are not suffering from isolated systolic hypertension. Their systolic blood pressure as well as diastolic blood pressure rises in tandem, and both of the readings are on a higher side in patients suffering from hypertension in routine. Then types or classifications of hypertension. Hypertension is broadly classified into two groups: primary or essential hypertension and secondary hypertension. So the primary hypertension is also called essential hypertension. It has unknown etiology. So basically there is no specific cause for a patient suffering from primary hypertension, but it tends to be familial. If there is a family history of hypertension, then there are high chances that the patient will develop hypertension eventually. but it depends upon the patient whether he or she will develop it very soon or very early in their life, or they will develop after 65 to 70 years of the age. Consequences of an interaction between environmental and genetic risk factors constitutes about 85 to 95% of the cases in adults. So basically, more than 90% of the cases of hypertension are of the patients who are from suffering from primary hypertension. Then there is another hypertension called secondary hypertension, and this hypertension is also called hypertension due to any other disease, and it constitutes 5 to 7 20% of the cases in adults. And it stems from specific etiology causing BP elevation, which can be identified and possibly treated, for example, hyperparathyroidism, pregnancy, renal artery stenosis, catecholamines, secreting tumors. So these are all the diseases basically which cause the hypertension in a patient. So these diseases result in hypertension in a patient as a consequence. So the patient is not suffering primarily from the disease of hypertension, but patient is suffering from some other disease, and that disease is consequently resultingly causing hypertension in the patient as a consequence of the disease or as a side effect of that disease. So basically, there is a infographic diagram which shows as primary hypertension to have no specific cause which is known, but there are some identified risk factors for primary development of primary hypertension, such as age of the patient, obesity, excessive salt and alcohol consumption, and physical inactivity such as sedentary lifestyle, a patient suffering from diabetes, a patient routinely smoker who is a routinely smoker. So basically, smoking also increases vascular resistance of the blood vessels of our body, and it results in hypertension in the patients. But diabetic patients are also prone to develop hypertension, and physical inactivity is also a major risk factor for developing hypertension in middle-aged patients. Then there is secondary hypertension, as we have already told. It is due to hyperparathyroidism or adrenal gland disorders or estrogen containing or contraceptives, etc., etc. There are many other causes of secondary hypertension as well. And in all these conditions, blood pressure is more than unanimously more than 130 to 130 over 80 millimeter of mercury. So the complications of the hypertension are atherosclerosis, heart failure, brain aneurysms, renal failure, hypertensive retinopathy, etc. So pathophysiology of hypertension, now we will discuss. So pathophysiology of hypertension is very straightforward. So basically, when there is increased vascular resistance, when our blood vessels are creating a tight pressure from outside, then these blood pressure contract, their muscles contract, and it increases the blood pressure of body. But routinely the blood pressure is not increased in normal individuals, and our blood vessels are not that much tight, their tone is not that much increased, and thus blood pressure remains within normal limits. But when there is a problem with this pathway, when there is a problem with this system, when there is a problem with the blood pressure control mechanisms in our body, then the blood pressure starts to go up. There are cardiac volume sensors in our heart tissue, and these cardiac volume sensors usually keep secreting a hormone which is called atrial natriuretic peptide. This ANP hormone then secretes, it causes natriuresis. So natriuresis means the loss of sodium in urine. So if we take too much salt in our diet, our cardiac volume sensors, which keep sensing our blood volume in our body, they sense that we have taken too much salt, and salt attracts water. So our blood vessels have been filled with salt and water, and there is a volume overload in our vascular system. Then our heart tissues release this peptide, which is called atrial natriuretic peptide. This atrial natriuretic peptide causes, first of all, causes vasodilation. Vasodilation means the dilation of blood vessels, especially arteries and arterioles. And this vasodilation causes increased space for the blood to accumulate in the blood vessels, thus decreasing the blood pressure. Then there is another effect on the kidneys by this enzyme called this hormone called atrial natriuretic peptide, and what it causes is it causes the kidneys to excrete sodium and water, and this decreases the blood pressure. And now no low volume or low resistance can also be renal artery stenosis as well. Then renal pressure and sodium sensors of the kidney release renin, which ask the body to increase blood pressure. And then this blood pressure is increased by renin by converting angiotensinogen to angiotensin 1, and this angiotensin 1 is then converted in the lung epithelium to angiotensin 2 via angiotensin converting enzyme. And then this angiotensin 2 then goes to the blood vessels and causes direct vasoconstriction of the blood vessels. But this angiotensin 2 also causes another thing. It goes to the adrenal gland of our body and it causes secretion of aldosterone. And then this aldosterone is a mineralocorticoid. It causes retention of sodium and water, and when sodium and water are retained in our blood vessels, then blood volume increases, and this blood volume then increases the blood pressure. So basically, this is called ROS pathway, renin angiotensin aldosterone system. So this pathway basically directly increases our blood pressure in the long run, and the way it does is basically it creates hormones which create pathways where blood pressure of the patient increases. So now we come to the theory. So pathophysiology of primary hypertension is multifactorial and highly complex. Yeah, primary hypertension is not solely relying on these pathways. There are many factors and many complex mechanisms involved which cause the hypertensive crisis in any patient. So important factors implicated here include genetic specific angiotensinogen polymorphisms and angiotensin 2 receptor variants have been linked to hypertension. Activation of neurohormonal systems such as sympathetic nervous system and renin-angiotensin aldosterone system. Then environmental factors such as stress, obesity, smoking, physical activity, and high levels of salt consumption modify the impact of genetic determinants. Then interplay of the factors above lead to altered renal sodium handling and increased vascular resistance, which ultimately contribute to essential hypertension. No, there is another pathway. This is a bit complex pathway, but I had to add it. I will not go into the details of this pathway as this path, the basic and the complex detail of this pathway are basically out of scope of this lecture. But I will touch some of the things. So basically, this pathway is in obese individuals. That is why I had to add this pathway. So if a person who is obese and who is having a sedentary lifestyle, then that person is gonna develop insulin resistance. Just like we studied in our last class, that a person who is obese and who is having a sedentary lifestyle, who does not do daily activity, who is physically inactive and who does not take care about his or her diet and who has become obese as well, then there are many changes in their body which result in hypertension as well as development of diabetes mellitus. So there is a constant state of hyperinsulinemia. So there is insulin resistance, which due to counter this insulin resistance, our body creates more and more insulin. Our pancreas creates more and more insulin. So there is hyperinsulinemia. Then there is hyperuricemia, and there is increased DPP4. DPP4 is basically an enzyme which uses the insulin in our body and causes insulin it to work out properly. But when there is insulin resistance in our body, this DPP4 level increase. And when all of these levels of insulin, uric acid, and DPP4 increase, they activate the renin-angiotensin-aldosterone system. And as I've already told, what is renin-angiotensin-aldosterone system? This system basically converts angiotensinogen to angiotensin 1, then angiotensin 1 to angiotensin 2, and this angiotensin 2 then causes vascular resistance increase as well as aldosterone levels increase. So basically, these pathways are activated, and then there is another pathway called visceral adipocyte dysfunction. The visceral adipocyte dysfunction also causes the release of many inflammatory markers, and these inflammatory markers then cause renal dysfunction as well as dysfunctional immunity as well. So this adipocyte dysfunction problem then causes renal dysfunction as well as vascular dysfunction as well as cardiac dysfunction, and all of these problems then create a recipe for disaster. So all of these problems then create hypertension in a patient. And then there are some risk factors. Some of the risk factors we have already touched in our previous slides, but then I wanted to go through every risk factor separately as well. So there are some risk factors for primary hypertension. The most common and most important, one of the most important risk factors for primary hypertension is age. So for men, it's more common for age 64, and for women, it's more likely to surface after age 65. So basically, it's a disease of middle to old age patients. So if a man is above 50 years of age or 55 years of age, he is likely to contract hypertension as a disease as well. But for women, the development of primary hypertension is a bit delayed, and it occurs after 65 years of age. That is why we keep listening that the women live longer than men. So basically, it's one of the reasons of women living longer than men is the low incidence of hypertension, diabetes, and heart failure in women than in men. More men die due to heart failure, hypertensive complications, and diabetic complications than women die. That is why there is usually a school of thought that women tend to live longer than men. And then there is another important determinant that is called race of the patient. So it's more common among black people and at a younger age than it appears in white people. Then being obese or being overweight is also a risk factor. Then we have already discussed it repeatedly that lack of exercise causes lack of exercise or sedentary lifestyle causes hypertension as well as heart failures as well. Tobacco use or vaping, it also causes hypertension. Then excessive salt consumption is also implicated in the development of hypertension. And then low potassium diets are also implicated in the development of hypertension. Then excessive alcohol use is also implicated. And then the stress in life, overall presence or absence of stress is also a major determinant in the development or not development of hypertension as well. Now, if a person has developed hypertension, then how will we come to know that XYZ person is suffering from hypertension? So signs and symptoms of hypertension we will discuss in this slide. So many patients are asymptomatic. That is most important because you will not find a person to be suffering from routine headaches, to be suffering from routine anxiety attacks, and to be suffering from all of these symptoms which are shown in the infographic diagram. And patient will may complain of just heavy headedness and nothing else. And you just out of routine checkup you just check their blood pressure and it is more than 160 and 170, and you tell the patient about high blood pressure and the patient is in shock because patient does not believe you. Why? Why patient does not believe you? Because many patients are suffering from chronic hypertension are asymptomatic. As hypertension develops over longer periods of time, so many of the patients do not even know that they are hypertensive, and they come to know during routine clinical examinations that they are suffering from hypertension. So hypertensive headache generally occurs only in patients with severe hypertension and not in a patient who is suffering from very mild or moderate hypertension. Even you can experience headache in moderate hypertension, but not in the cases of mild hypertension. The pain and of the hypertension characteristically occurs in the morning, and it localizes to the occipital region. So basically, posterior aspect of neck and posterior aspect of skull are implicated in hypertensive headaches, and patient complains of the headaches in those regions as well. Other non-specific symptoms include dizziness, palpitations, easy fatigability, and impotence, and uh, anger which is out of control. So presence of symptoms mostly indicative of hypertensive cardiovascular disease or to manifestations of secondary hypertension. So nosebleeds are common, headaches are common, chest pain is common. Sometimes there is also blood in urine. Sometimes there is shortness of breathing. Sometimes there is vomiting or nausea. Sometimes there is palpitation. Sometimes there are dizziness. Sometimes there is a complaint of blurry vision as well, because hypertension also causes covert and organ damage. So even if we don't know whether we are hypertensive or not, whether we are suffering from headache or not, but hypertension is a silent killer, just like diabetes mellitus. So it keeps damaging our kidneys, it keeps damaging our eyes, it keeps damaging our heart. That is why all of these are common symptoms of hypertension as well. Then most common complications of hypertension, we must know what are the most common complications of hypertension. So following complications have been reported with uncontrolled hypertension in multiple large-scale population trials. So chronic coronary heart disease is also linked with hypertension, myocardial infarction, cerebrovascular accidents, which is also called stroke, hypertensive encephalopathy. So basically, if a person is suffering from one more than 180 millimeter of mercury hypertension, then they are more prone to develop hypertensive encephalopathy, which damages the brain of the patient. Renal failure, acute versus chronic, both occur in hypertension. Then there is peripheral arterial disease. Then there is atrial fibrillation, aortic aneurysm, and death. So usually due to coronary heart disease, vascular disease, or stroke related. So basically, hypertension may lead any patient to death by all of these complications. So that is why hypertension contributes to 7 million deaths worldwide annually. That is why. Because hypertension does not kill you directly, it causes these complications. There are strokes related to hypertension, there are uh, episodes of myocardial infarction related to hypertension, there is development of coronary heart disease, and there are developments of renal failure, atrial fibrillation, aortic aneurysm. So are potentially all of these problems are potentially life-threatening. I'm sorry, I'm basically doing some extra duties. That is why I'm stressed as well. There are some emergency duties given to me these days, and I have to perform those emergency duties as well. So I am a little bit overworked these days as well. I performed 12 hours duty today as well. So basically, there are many complications of hypertension, but the uh, most common and most life-threatening problems which are occurring in hypertensive patients are myocardial infarction and stroke. So these are basically the life-threatening problems which occur in hypertensive patients, and they are killing many patients worldwide annually. So, how do you approach a patient who is suffering from hypertension? So, we should know how to approach a patient with hypertension first. So, first of all, presence, character, and duration of symptoms. First of all, we ask the patient what do they know about their disease. So then we check whether the disease is present or not. Even if the disease is present and if there are some symptoms, what is the character of those symptoms? Are they mild? Are they moderate? Are they severe? And what is the duration of those symptoms? Whether these symptoms are chronic, whether these symptoms have developed over the period, over the short period of time, and what is the time of first diagnosis. So, current and past BP values are also assessed. Current and past antihypertensive medications and any other medication responses and side effects of those medications are also assessed. Then, family history of hypertension and other cardiovascular disease, lifestyle evaluation, exercise, body weight changes, diet history, smoking, alcohol consumption, recreational drug use, sleep history, impact of treatment on sexual function as well. So all of these things are assessed and asked in your history. Whether patient is suffering from these diseases, whether the patient is suffering from these problems, whether patient does exercise or not, whether there are any recent body weight changes as well, what is the diet history of the patient, whether the patient is smoker or not, whether the patient takes alcohol or not, because all of these are risk factors for development of hypertension. And history of any comorbidities such as diabetes mellitus, it is also very important because many of the diabetic patients, many diabetic patients also suffer from hypertension as well due to autonomic system collapse. History continued. Then we asked the questions related to secondary hypertension. We dig in further and try to know whether the patient is suffering from primary hypertension or the rare disease, which is secondary hypertension due to any other disease as well. We ask about any history of renal disease, any history of muscular weaknesses, any history of spells of sweating, palpitations, and tremors, which is basically pheochromocytoma or endocrine tumors of the adrenal gland. Then we ask about erratic sleep, snoring, or daytime somnolence. It is basically obstructive sleep apnea, which occurs in obese patients. And then symptoms of hypo or hyperthyroidism. We do ask the patients about hyperthyroidism as well because hypo or hyperthyroidism both can cause changes in the blood pressure as well. Then whether patient is using any medications which may increase the blood pressure as well. So we ask these questions to rule out secondary hypertension. Then we ask and assess evidence of target organ damage. So we ask about history of transient ischemic attacks, stroke, or transient blindness. Then we ask about any history of angina. So angina is basically heart pain. Mostly angina is characterized by heart pain due to activity, but there is also an angina which is called unstable angina, in which even a patient who is at rest, they are suffering from heart pain due to ischemia of the heart muscles. Then there is myocardial infarction, congestive heart failure, sexual function. So we also ask patient about whether there is any kind of organ damage or not. We check the eyes of the patients as well. So how do we examine a patient with hypertension? We look at the body habitus of the patient, whether the patient is whether the patient is having normal weight, whether the patient is obese, whether the patient is thin lean. We also check the waist circumference to diagnose metabolic syndrome and type 2 diabetes mellitus risk, because if the waist abdominal obesity is present and the waist circumference of the patient is increasing over the course of few years, past few years, then the patient is about to develop metabolic syndrome due to abdominal obesity and hyperinsulinemia. Then we check the measurement of pulse rate and we check the BP, then neck palpation to check any kind of thyroid enlargement, then auscultation for bruise over the carotid and femoral artery. It rule out peripheral arterial disease. Then we examine the heart of the patient, and if there are any abnormal heart sounds or not, then any abdominal bruit as well that lateralizes and extends towards systole into diastole is renovascular hypertension due to renal artery stenosis. Then, after detailed physical examination, there are some lab tests such as urine analysis, blood glucose levels. So, urine analysis for evidence of kidney disease, blood glucose level for diagnosis of diabetes, full blood count for checking whether the patient is anemic or not, because there are chances the patient is anemic in chronic kidney disease. So, CKD is basically chronic kidney disease. Then there is creatinine levels, electrolytes levels. So these creatinine and electrolyte levels are checked to assess the renal function of the patient. Then we check the lipid profile, because dyslipidemias or hypercholesterolemias or increased levels of cholesterols or lipids in the blood, also called hypertension, and they also increase the cardiovascular disease risk factors. Then we also perform the ECGs. So these are routine investigations. Then there are some specialized tests. If these routine investigations came back negative and we are suspecting whether the patient is suffering from some secondary form of hypertension, then we may check thyroid function tests. We may screen the patient for renal artery stenosis. Then we may check whether the patient is suffering from Cushing syndrome. There is a test called dexamethasone suppression test. Then there is a disease called pheochromocytoma. It is a tumor of adrenal gland which secretes too much catecholamine or metanephrine in the blood. So we check urinary metanephrine levels or plasma metanephrine levels. Then primary hyperaldosteronism is also a cause of hypertension. So we may check the patient's blood level for aldosterone levels as well. So, how do you diagnose a patient with hypertension? For example, if there is a patient and you're suspecting the patient to be hypertensive, how do you diagnose? So, there is a proper criteria for hypertension. The patient should be taking rest. The patient should be well rested. The patient should be sitting in a proper posture, and the arm which is used to check the blood pressure should be at the level of the heart, and the patient should be relaxed environment. Patient should not have smoked, should not have ingested caffeine, should not have any kind of food in previous 30 minutes. Patient should not have any kind of stress in his or her mind. An appropriate size of BP cuff should be used, and it should be tied 1 inch above elbow joint. And then there's a proper methodology. You check the BP after 1 and 3 minutes of standing at first consultation in the elderly diabetics and patient with arterial hypertension is common. When adopting the auscultatory method, use protocol sounds as well. So basically, there is a criteria of whether the patient is suffering from hypertension or not. So these are the rules. These are the methodologies which are used to assess the patient's BP properly. So that is the criteria for diagnosing hypertension. So in office blood pressure measurements, if a patient is suffering from more than 40 millimeter of mercury on two separate occasions, then that patient is labeled as hypertensive. In office measurements, for example, in the doctor's office, if a patient is checked twice on two different occasions and the patient's BP comes out to be more than 140 millimeter of mercury in systolic blood pressure and more than 90 millimeter of mercury in diastolic readings on two separate occasions, then the patient is labeled as hypertensive. But daytime hypertension or ambulatory blood pressure readings and nighttime hypertension or ambulatory blood pressure readings during night are different, because if a patient is sleeping in during rest timings and still their blood pressure is raised during sleep to more than 120 millimeter of mercury, the patient is straight away labeled as hypertension, and you need not to wait for the blood pressure to cross the mark of 140 in order to label the patient as hypertensive. If the patient is in sleep and the patient's blood pressure is raised more than 120 millimeter of mercury. And home blood pressure criteria is a blood pressure of more than 135 millimeter of mercury um, to be labeled before a patient should have more blood pressure of 135 millimeter of mercury in order for us to label them as having blood pressure or and as having hypertension. So this is our last topic, and that is treatment of hypertension. I have not gone into the extensive details of how to treat hypertension pharmacologically and medically, because these things would have gone out of the scope of this lecture. So I have added some basic treatment plans, some basic treatment options to keep the things as basic and as easy as possible. Because if I started going into the detailed treatment options for hypertension, then this lecture would have reached the doctoral level and not the graduation level. So the first and foremost step in management of hypertension is lifestyle modifications. We all know that, and we know that what is healthy lifestyle. We have been discussing it a lot. We have discussed it in our previous class as well, when we discussed how to control the development of pre-diabetic stage and how to control the development of full-blown diabetes. And there were many lifestyle modifications, and those lifestyle intervention or those lifestyle modifications are applied on at risk hypertensive patients as well. So weight loss, we encourage the patient to do a weight loss, and they should, if a patient is having a BMI of 32 or 31 kg per meter square, we encourage the patient to lose their weight so that their BMI should be around 18.5 to 24.9 kg per meter square. Then dietary approaches should be there, and there is a term called dash. So this there is dietary approach to stop hypertension. Diets high in vegetables, fruits, low fat, dairy, reduction in total and saturated fat. So basically we do not take any kind of sugars, we do not take saturated fats, and we take low fat dairy products for the management of hypertension. Then we ask the patient to decrease their salt intake. We ask the patient to do 30-minute aerobic exercises most days in those who are able to do exercises. For example, if a patient can perform exercises and is physically fit with no musculoskeletal problems, then the patient should be encouraged to exercise 3 or 4 times a week with exercises, at least 30-minute exercises in those 3 or 4 days per week. Then alcohol consumption and cigarette consumption is another major risk factor, as we have already discussed. So the patient should be encouraged to drink less than 2 pints of alcohol per week. And all of these lifestyle modifications are associated with reduction in blood pressure and prevention or delay of hypertension and enhancement of hypertension treatment. And they also decrease the cardiovascular risk reduction. Then prevention strategies are further discussed, such as maintaining a healthy weight, eating a healthy diet, being physically active, quitting smoking and drinking, reducing sedentary behaviors. For example, prolonged TV watching is also linked with development of hypertension in early middle ages. Then reducing stress in our lives and getting support for stress and weight management. So the patients are encouraged to join the groups who help the patient in decreasing their weights and stress in their life. Then there is pharmacological therapies. There are some classes of drugs such as renin, angiotensin, aldosterone system inhibitors, beta blockers, calcium channel blockers, thiazide-like diuretics, aldosterone antagonists, and other sympatholytics, adrenergic blockers, and centrally acting alpha-2 antagonists or direct arterial vasodilators as well. So there are some examples then you can read this table by yourself. There are some examples of diuretics, there are some examples of angiotensin uh, receptor blockers or ACE inhibitors. Then there are some examples of beta blockers such as metoprolol, nebivolol, propranolol, etc. Then there is a drug called bisoprolol, which also is a beta blocker, and these are very good agents in controlling blood pressure. Then there are calcium channel blockers such as dihydropyridine, amlodipine, nifedipine. Then there are direct vasodilators which decrease the tone of our blood vessels, such as hydralazine, minoxidil, tirazosin, pyrazosin, etc. Then there are some centrally acting agents such as clonidine, methyl dopa, aldomet. Methyl dopa is basically used in pregnant females. It's safe in pregnancy and it's used extensively in pregnant females. So these are the drugs which are basically used in many of the patients. So these drugs are just available drugs, and these drugs are not to be given to patients arbitrarily, because there are some patients who are fit to take beta blockers, and there are some patients who cannot take beta blockers. And just like that, there are some patients who are contraindicated to use calcium channel blockers, and there are some patients who can easily take calcium channel blockers. So these drugs cannot be used arbitrarily. These drugs should only be used after proper medical consultation with your general practitioner or your internal medicine specialist. And these drugs should be taken with extreme care, because many of the drugs written here are nephrotoxic. Many of the drugs written here cause some other multitude of other problems as well. So if even if they treat your blood pressure, they may cause some other side effects as well, which may be detrimental to your well-being. So these drugs are always to be used under supervised medical care, and they are not to be used over the counter medications. Have a nice day. Thank you. So yeah, are there any questions, please?
Thank you. We can allow 5 minutes of questions since we run out of time. So let's see what Lamin. There are a few questions in the chat box. For example, from
Okay.
Cardis Khan, is genetic take roles to find the hypertension?
Let me see the chat box, ma'am. So let's open the chat box. I'm unable to open the chat box. Basically, where is our meeting? Okay. I'm unable to see the messages in our chat. Where is, are they direct messages? Hello,
I
ma'am.
do have them. I do have them. So one of the questions is from Safo Boye. She asked, what amount of sodium intake is considered high for hypertension patient?
So basically, a hypertensive patient, if the patient is suffering from mild or moderate disease, they can take up to 2.5 grams of sodium chloride or table salt daily. But if a patient is suffering from severe hypertension, they should be encouraged to take less than 2 grams of table salt per day. So it is like that. But these uh, guidelines are not specific, and these guidelines are not for the whole world. There are some countries where there are different guidelines, so you should follow the guidelines of your own country's health organizations.
Yeah, I have another question here from Christian. He asked, what are the simple health practices to avoid or reduce the chances of contracting hypertension?
So we have already discussed the things in detail. So basically, if there is a family history of hypertension, just like my family, there is a strong family history in my um, maternal uncles and maternal aunts and maternal grandparents, and there is a strong family history in my paternal grandparents and my paternal uncles and paternal aunts, including my father, including my mother. All of those people suffered from hypertension after the 45 years of or 40 years of their age. So there is a strong family history. So in my case, so I am giving my own example because I can correlate with my example, and I can make my students understand clearly. So I am a textbook case of a high risk person who can develop hypertension at any stage of life due to strong family history from my mother as well as from my father. So what can I do? So what do I do? I always take care of my salt intake. I always try not to take too much sugars. I always try not to take too much saturated fats and too much junk food. I try my best to be as active as possible, although I'm not that much active these days due to the stress of the job, uh, due to the professional life responsibilities. But yes, the things which you can do is you can take care of your diet, you can stay active, you can stay stress free, and then you pray to God that you do not develop this disease as early as 45 or 50 years of age, and you try to delay the onset of the disease to as late as possible. So there is another question: why is hypertension and diabetes most common in elderly? A very good question. So basically, there are some people, the elderly, especially, so the tone of the blood vessels or the elasticity of the blood vessels decreases in old age. So basically, in young patients or in young individuals, the blood vessels are more elastic.
Dr. Omer, are you there? I think we lost him.
Elastic with the development of
Yes.
the age. There are many reasons for that. I cannot go into the details of the reasoning for it because it will move our discussion to some other direction. But basically, there is a term called atherosclerosis or arteriosclerosis. So basically, there is sclerosis called fibrosis. So their arteries or their veins are basically sclerosed. They're not that much elastic or they're not that much muscular in late ages. So that is why after 50 years of age, patients start developing such diseases because their arteries are less elastic in old ages.